Thank you very much for coming. We have three excellent speakers. Yeah, today we have three excellent speakers, starting with Laurence. Take it away.
Thanks, Anna. So, thanks very much for coming along. You might have heard something about the HDRCs, or if you haven't, you're intrigued to find out something about the HDRCs. So thank you for coming, and I've obviously got quite a short presentation now, so I'm very happy to speak to any of you further on. But my aim is to give an idea of why HDRCs were set up, what they are, what we're doing in Glasgow, and how you can get involved and what the opportunities are for you. So, without further ado, why did NIHR fund HDRCs? Well, I put this down to Chris Whitty. So before he became super famous in the COVID years, when he first took up his post as CMO in England, but also head of NIHR, he really felt, and had obviously been advised, that public health research was not delivering and not having an impact in the way that it should do. And he's had a whole series of interactions with a wide range of people, including a few academic workshops, and I attended a couple of them. He's also said, what can we do? What can we focus on to really transform the quality and impact of public health research? And he was coming from a background of having worked a lot in global health, and he'd been very much involved in the Sustainable Development Goals and how they had really brought traction and focus and really ramped up the pace of delivery generally in global health research, but particularly in the areas relevant to the SDGs. So initially the discussions were, should we focus on obesity? Should we focus on mental health? These kind of topics, what could be the UK public health goals equivalent of SDGs? But what I said, and lots of people sort of said, well, it's not as simple as that. You can't carve it up like that. So many things are interdependent. And then maybe actually the critical issue is kind of like inequalities. Health inequalities and the interdependence of different kind of outcomes relating to those circumstances in which people live their lives, and the drivers, particularly the upstream wider determinants of health that drive that problem. So he listened, which is great, and I think after he'd seen the usual suspects, I think he then did quite a lot of interactions with local authorities, because he recognised that if you're going to do something about health inequalities, you need to attack and address the wider determinants of health, and the levers on the wider determinants of health do not exist within the NHS, within the clinical research communities, etc., etc. So if you're going to impact on health inequalities, you've got to involve them. And then what is kind of, might be a bit harsh to say absence, but what the local authorities do not have, and of course in England there's a big focus on this because the public health workforce transferred to local authorities were kind of struggling with this issue. They just don't have research capacity. They don't have a culture of research. They haven't been trained in the way that clinical, the wider clinical workforce have all had training in kind of evidence-based medicine and the whole kind of idea about collecting data and feeding that back so continually to improve efficiency in practice and innovation, etc., etc. So this was his key agenda: health inequalities, the key context, local authorities, the key need to drive up research capacity and culture, and also to bring into that kind of initiative in the English context, not just the public health workforce and the DPH team and whatever, because even that would still be a bit kind of individual and proximal and a bit downstream around services and what have you. You've got to involve the people who are making decisions about the wider determinants of health in that local authority context. So HDRCs were developed to kind of bring about that transformation, address this kind of capacity issue. Each HDRC gets £5 million for an initial 5 years. There's a high possibility of renewal. They've managed to get the £30 million in the recurring budget of DHSC. So that there is a high possibility of renewal beyond the initial 5 years, and those first wave HDRCs are now putting in their renewal bids, because they're heavily into their third years. And it's really about that capacity, capability. The bids have to be led by the local authority. So the lead, Kimberly Hose, is the lead of the Glasgow HDRC. She's council employee, head of data, data intelligence or something at the council. And the funding is really to build that capacity, change that culture. It's not really about delivering specific research project, albeit, as you'll see, we have built that research delivery into our bid, which a lot of the earlier HDRCs didn't. So the Glasgow vision: improve the health of people of Glasgow by embedding research practice collaboration across the City Council, its partners and communities. So a focus on research practice and culture, focus on the wider determinants of health, and really focus on making this sustainable. So with the council, do not see it as a 5-year thing. Even if the NIHR don't provide renewal funding, the council intend to pick it up and really embed this whole way of working in the way Glasgow City Council works on its own, but also with the community planning partnership members. So these are the kind of things we will do. I won't go through each of those in turn. They all kind of make sense, hopefully. The bid we put in was a partnership of 3 key kind of organisations: the City Council, the University of Glasgow, NHS Greater Glasgow and Clyde. One of the things that happened fairly recently with the SPHSU closing, Shona Hilton was part of it. Was me, Peter and Craig, and Shona Hilton put in the bid as the University of Glasgow co-apps. Shona's now gone to Strathclyde, so University of Strathclyde are also part of the partnership team. And then we're also very much involved. So the NHS, particularly represented through the HSCP, the existing Glasgow City Health and Social Care Partnership, and also GCPH and Chick and Pete from GCPH are involved in the delivery team, co-applicant team. We have a logic model. We keep refining this and keep changing it. So we've got 3 kind of work streams, and I won't go through this in detail, but we've got an idea of what we're doing, but we keep having to update this, and the outcomes and the intermediate outcomes that we've got there. You obviously can't read them, are linked up to those objectives I've already set out. The initial focus for Glasgow is child poverty. This is partly because this is the council's grand challenge mission. It's also in part because a lot of the people and a lot of the kind of momentum we've been able to kind of key into in the council is the work of the Child Poverty Pathfinder, which was a research practice collaboration. And the 3 kind of main strands of Glasgow's concerted action on child poverty are these 3. So we're doing work in all of these areas, particularly doing a lot of work with employability at the moment to work out how we can support them. We were a bit disappointed momentarily, but then absolutely delighted that our bid wasn't successful in winning 5 years funding. We actually had a development year funded, which gave us 6 years. So in our development year, we could do an awful lot of the preparatory work that is really, really helpful. So 2024, we were doing that preparatory work. 2025, we've really kind of started. And we expect by the end of our kind of 6 years, so the end of this decade, so 31st of December 2029 is when the first tranche of funding finishes. We really hope to have achieved significant progress in all of these areas. And as I say, we keep updating our programme theory, our logic model, as we learn more from the council about what they want from us and how they can work with us. So we're continually adapting this. One of the things that was, I think, particularly interesting and strong about our bid, which wasn't present in some of the earlier HDRCs, is we have included quite a pot of kind of funding, and that's most of the staffing in the University of Glasgow, is to support our ability to adopt or affiliate projects and to put some significant HDRC resource in making sure those projects are delivered. A lot of the other HDRCs are focused on culture change and training and developing an appetite for R&D, but they haven't actually had any resource to deliver it, and the councils haven't had any resource to deliver it, so it's been a real problem for them. And we are in the process of changing this, but in our initial kind of bid, we kind of set aside that we would have this process of identifying, what were the demands, what were the questions coming through from the council that we could then kind of assess about whether we would help them with an initial policy appraisal, or very often we might do some kind of evaluability assessment, and subsequent to that, take that through into an evaluation. And then also some of the projects we might be asked to take on are really just synthesizing what's currently known and helping drive forward implementation. So we have updated this. This is there to say we have resources and we are refining our process. We've pretty much finished it now, the refinement of it, to adopt projects and support them. In our development year, we did achieve a lot. It was mostly listening and refining what we were planning to do. We made lots of changes in response to what we heard from the council and the wider partners. I've rattled through that. What I particularly wanted to highlight with the audience today is what the opportunities are for you. I very much appreciate you coming along today. If your research is relevant to the council or might need council support to be delivered, I mean, we can help get the council to provide the support you're looking for. We're working with the council to review and refine their academic advisory group and the whole kind of process they have in terms of writing letters of support and then generally engaging and supporting academic-led projects. I mean, it's really interesting. When I spend a day and a half a week down in the council, either in person or sometimes virtually, and it's just really interesting to see things from their perspective. And what they really want us to do is to help them move away where they're just responsive to kind of random approaches from academics who want to do a study which they feel obliged to write a letter of support for, but actually it isn't really work that's critical to them. There's other questions that are much more critical to them where they want us to help them. There's lots of opportunity to do that, and they're going to get a bit more on top of it with our assistance in making sure they bring more academics into working with the council, but actually on things that are relevant and important to the council, and therefore have much greater chance of being mainstreamed and implemented and taken up because of the strength of the policy fits and the real engagement. Some of the specific ways in which we might be able to help you with a project that you're wanting the council to get involved in here, but I think the critical thing is the earlier scoping and dialogue to make sure that we're spending our time as academics working on questions that are important to them, because they are the important questions, and they are the ones that will generate impact and be deliverable as well, both in terms of the research phase and the beyond research phase. The other thing is, because we are getting these asks now from the council, we've done one, and we'll be doing other evaluability assessments already, and or just kind of program theory mapping, logic model mapping, this kind of thing. We expect there to be a pipeline of research questions coming through to the council, which are high priority to them. They're going to kind of do this anyway. They want us to help them with it. So it's a really great opportunity to do applied impactful research by making sure we communicate and you engage with the opportunities that are arising. Because what we do not intend is the HRC to be a closed shop where all the best ideas are just picked up by me, Peter and Shona. We want you guys, we want to be facilitating that as a range of opportunities for you to engage in. So we will adopt and affiliate studies. I think a lot of the studies that might come from you guys will be ones we just affiliate. So we might help you put you in touch with the right people, help you put you in touch with the kind of key data sets, etc., etc. Some of them might be more adopted, where some of our resource can be significantly put in to that. And the thing that's very clear and has been said to us, this is particularly the public health research programme within NIHR, they really want to see bids coming from the HDRCs, and I think that is going to give a real strategic kind of uplift in competitiveness of bids if you're genuinely engaging with the council. And we can put you in touch with 30 HDRCs. We're working particularly with Liverpool and Newcastle at the moment, and we've had some discussions with Manchester and some of the others. So there's likely to be some of the problems that are arising, some of the questions arising, both from Glasgow and some of the other cities that have got HDRCs, will be ones that are taken forward in collaborative bids with them, so you can do a multi-site kind of study. So NIHR Public Health Research Programme have made it really clear they want us to do that. Have I got 1 more minute? Start this, I don't know how many of you have seen this. This is David Ogilvie and colleagues wrote this quite a while ago, and this kind of identified that in the research we do, evaluation, applied intervention type research that we do, we tend as academics, and like the MRC guidance of the past has focused on the idea that actually we are the clever people, we academics, we can come up with great ideas, we can develop new interventions, take them through feasibility and pilot trials, do a definitive trial, pull together the results of that study with other studies, and then by magic, this will lead to kind of policy action. And this kind of model could be applied to improvements of clinical, most clinical innovation might come through an academic-led pathway. Also, changes in delivery and organisation of health services might come through this route. This is the way we organise our lives as academics. We think we come up with the ideas, and then we do this, and then we get really irritated when our findings aren't kind of listened to or implemented. And of course, this whole issue of getting impact is a real problem. But if impact's really important to you, let's think about the other way in which research can influence the efficient delivery of interventions and services and policy. This is so much of what happens in the real world. Is policy is developed, or a clinical intervention is brought into place, or health services are reorganised, and we haven't been involved. It doesn't come from our idea, because people on the ground in the front line realise they need to change something, and they've got an idea how it might be changed. They then implement it without having evaluated it yet. But then there's massive opportunities to evaluate what they're doing. So in the updated MRC guidance, we've got this. So it's not just about developing and evaluating interventions, it's about identifying interventions and doing natural experiments and doing policy trials or doing prospective or retrospective evaluations of changes in practice that are going on anyway. Because this is where so much is happening, which we're just not involved in that as much as we should be. And of course, that's where there is a huge potential to impact, because you're actually researching what's going on in the real world. So again, the HDRC is definitely massively lined up to support this mode of research as opposed to that mode. And being in the council, and kind of, you learn as you go through your career, you think, well, Christ, it's been talked about throughout my career, but we're still not really doing it. We're still not going to the people who hold the problem, whether it's in a clinic or whether it's in the council, and talking to them about what their research needs are, what their priorities are, and how can we help them. So I think we need to do more work in that way. The kind of things we adopt are likely to be these kind of things, often evaluability assessment, but might be a lot of ex-ante work. If they ask us to take forward an evaluation, sometimes we might have funding in the HDRC to do that, but usually this is where the pipeline for applications for further larger project funding will arise, and where there will be opportunities for you to get involved in this. And then a lot of the work they're doing, particularly around public service reform, is actually much more kind of complex, wicked system change. And so some of our staff are going to be like embedded researchers working in some of their teams to take that forward. But again, that links into the kind of approaches a lot of people are using, such as Gallant and Health Mod and others of us. So there's a real demand for that from the council.
Because we're a bit over time. Any questions at the end? If you've got them.
Yep.
Have a think about it. And if you just put the questions in the chat as well. Next up, we have Anna.
Thank you. Thanks, Laurence, as well. I think you've been using good foundations for this. So I'm just going to be talking about plans for an evaluation of the Scottish Child Payment. So we're just in the process of finalising and publishing a protocol, so really keen to get thoughts. This is funded by the NIHR through separate funding from the HDRC, but we're really benefiting from links. So this project's becoming really closely linked to them, and I'm benefiting from each of the kind of resource and collaborators that they have. So really briefly, there is really compelling evidence that child poverty is bad for kids' health. There's been a systematic review that's covered that heaps of depth, and there are, you know, some nice examples of causal analyses that are using observational data to show that poverty is bad for various health outcomes. And not only that, it can have an impact across the life course. So it affects health as an adult, but also educational outcomes and what job you end up with, that sort of thing.
Anna, sorry, would you be able to share the slides so the people online can see?
Yeah, of course. Sorry.
Thank you so much.
Realised. Here we go. Are you seeing that okay now?
Yes, thank you.
Okay, great. You haven't missed anything, really. It's a little bit of boring text. So yeah, hopefully we're all convinced that we need to be tackling child poverty, and luckily the Scottish Government is using its devolved powers to do some of that. So they've introduced the Child Poverty Act, they've set targets, they've published a national action plan, which is focusing on the key drivers of child poverty that they believe to be income, employment and cost of living. And then local councils are also kind of tasked with publishing their own plans and reporting back on those as well. So heaps of different things going on in that space. So based on what we already know from the literature around child poverty and health, whether that be observational analyses or there have been sort of natural experiments of income transfers in other countries, we know that this is likely to be making children's health better than it otherwise would have been. Not saying over time it's going to be improving, but hopefully it won't be as declining as fast as it would have done in the absence of these policies. But there's still heaps of unknowns. So some of the things that we want to be thinking about are, yeah, how much is health being improved? If it is, are these policies reducing social inequalities? Are they more supportive for some groups than others? So are there potentially differential effects? And then what are the policy tweaks that we could potentially make to make policies more supportive for kids' health? So that's thinking about things like dose, eligibility criteria and the content of those policies. So we've got funding from NIHR to be doing this over the next 4 to 5 years. One of the first things we're going to do is evaluate the Scottish child payment. So it was introduced in 2021. It was £10 a week for under sixes. At that point, it's since then has been doubled to £20, increased again to 25, and the eligibility criteria also widened out. So it went from children under 6 up to any child under the age of 16 who is living in a low-income family. In terms of eligibility, that sort of low-income family is proxied by receipt of universal credit or equivalent benefits. There are no conditions attached to the Scottish child payment. It takes 10 to 20 minutes to fill in the form. You can do that online or you can do it over the telephone with support, including a translator if needed. And uptake has been increasing over time, and now it's pretty good, but we still have quite a lot of geographical variation shown there. So dose right now is £27 a week, which is around £1,400 a year per child. So if you have more children, you meet the eligibility criteria, you get that amount of money for each of them. So far, Scottish Government have done some modelling and they've estimated that Scottish child payment has kept 40,000 children out of relative poverty in this coming year. So our aim is to evaluate the population level benefits on health in the early years, so for children and mothers, and also to look at how socioeconomic inequalities may have changed. And then we've got a secondary objective, which is to look at whether the impacts have varied for different groups. So we want to look at geography. So this is a national evaluation, but we're very closely tied in with Glasgow City Council. So we want to be looking in more detail how things are working there. Also want to look at differential effects according to the priority family group. So this is 6 family types identified by the Scottish Government as being particularly vulnerable to poverty. And then we've also had some other groups of interest that have been identified by stakeholders, in particular deep poverty. So we're not necessarily looking for Scottish Child Payment to have shifted all families above the poverty line, but we know that it will be really helping families who are way below that. But the protocol has been informed by an evaluability assessment. This was led by Michal from SPHSU. So we had a couple of workshops, updated the Scottish Government's theory of change, talked about priority outcomes. So we were looking broader than health, although health featured really strongly. The types of data sets, and then study designs for evaluation. So there are qualitative evaluations underway. So we decided to focus on a quantitative evaluation. And then in addition to that, we've been doing a bit more consultation with people in Glasgow. So we're taking this quantitative approach. Our population is all children born in Scotland between 2014 and 2025. And we're going to be focusing on the early years using a controlled interrupted time series analysis. So comparing trends in child health before and after the introduction and then the changes to the Scottish Child Payment. We don't, unfortunately, and I don't think we're going to get individual level data of receipt of the Scottish Child Payment. People are plugging away at this, but I don't think it's going to happen for us. So we're going to be using an intention to treat approach, very broadly speaking. So using area level, small area level data on the proportion of families living in dual poverty, and then throwing into the mix some socioeconomic characteristics as well. So things like social class and family structure. And so we're going to be looking at trends in health in the intervention group, quote unquote, so the children most likely to be experiencing poverty compared to those who are less likely to be. So we're using administrative data, so birth records, maternity records, hospital admissions, child health records, prescribing data, and then a few different geographical data sets as well. So SIMD, children living in low-income families, so that's what gives us the proportion of children living in poverty, and then also some census data, but at the ward level, which I'll come on to in a tick. So in terms of variables, we have yet to narrow down our health outcomes. They're still pretty broad. I'm doing some more stakeholder consultation next week when we're planning to get them really narrowed down. But areas that were important to them were child development, both physical and cognitive, and sort of socio-emotional, mental health, physical health, health-related behaviours. We're going to obviously have to account for how the population has changed over time when looking at our trends in the interrupted time series analysis. There'll be various things we'll be adjusting for. In terms of axes of inequality, we're going to be focusing on socioeconomic inequality using the relative and slope indices of inequalities. They give us a summary measure on the absolute and relative scale using SIMD, and then a measure of social class from birth records. And then we've got these stratification variables, which I've mentioned already. So this is starting to think about, is the policy working better for some groups than others potentially? In terms of numbers, we're generally doing okay for power. We've got a long study period. If we look at, it will vary from outcome to outcome, but if we're looking at monthly time points, then we've got 37, 12 posts. Our rarest outcome in theory right now until next week, don't know what that'll be, but is unintentional injury hospitalizations. So that's 1% incidence per annum. So we're looking at about 15 admissions in low income groups. So overall, we'll be doing all right for power, but I think when it comes to the stratified analyses, we're only going to be able to do that for the more common outcomes. And then sensitivity analyses, this is not all of them, I think we'll have a few, but some of them are going to include looking at different ways of classifying our intervention and control groups, looking at the possibility of having a synthetic control from England and Wales. So the concern here is slightly as the pandemic in particular changed things, and it changed inequalities. So having kids in the kind of below poverty threshold versus the above, we know things changed for them. So having England and Wales as a potential, well, particular areas from England and Wales to create a synthetic control. And then also looking at some negative outcomes as well. So things that we don't think could have been altered by the policy. Basically those that were that have occurred before the families would have been receiving Scottish Child Payment, so in pregnancy and at birth. And then longer term, once we've carried out this, the hope is to carry out some qualitative comparative analysis to understand if we get local variation in how the policy is working, to sort of drill down a little bit to understand how contextual factors might be altering that. Going to be evaluating some local interventions. As I mentioned before, there are local action plans each council has. We're going to be evaluating some of those for Glasgow, and then simulation policy tweaks. So this is a few years ahead for us just yet, but then thinking about how can policies like the Scottish Child Payment be even more beneficial to health and health inequalities. We can make changes. Thank you.
I think we have a few minutes for questions if anyone has any.
Thanks. They're obviously the Scottish Government are going to bring in the child's going to reverse. So is that part of it? The two-child cap? Or is it just purely on Scottish?
Yeah, purely on Scottish Child Payment. Yeah. I mean, that's one that's ripe for evaluation. Obviously, we will be taking that into account as some of the outcomes of where our time series overlaps with that. But one of the things we will be doing is looking at family size though, and how this is working for larger versus smaller families. So it's sort of feed into some of those conversations, but yeah, not directly.
Thanks very much. I'm sorry if I'm misunderstanding, but you said you weren't going to get the actual individual level data to see who was receiving the payment or not.
Yeah.
And then it made me think about the synthetic controls from other contexts where the payment's not available. Could you say a bit more about how you do that and whether or not that's more important if you're not actually seeing the actual who's receiving the payment?
Yeah. So I think because that is our biggest challenge, and it's a really frustrating one, but I think this is worth doing anyway. So we'll be taking the children living in low income families, so it is small area level, and that's measured right across the UK. So when we identify our intervention and control groups for Scotland, we'd be looking to use the same process in other areas of the UK, but then drilling down in particular local authorities where we know that they've got similar levels of poverty and demographic profiles as Scotland. So I expect we might even end up doing a south of Scotland versus north of England and maybe pockets of Wales. But it would require quite a lot of thinking through in order to do that. For the individual level data, so up here we were able to use social class and family structure and some of those bits that are in birth records. We're not going to be able to do that for England. We might be able to do it for Wales, so they might end up looking slightly different.
Is there any questions online? I have a question. So you mentioned in the slides that you might do some simulation about policy tweaks. Do you have anything in mind in particular about what you might focus on?
I've got things in mind that I'd like to do. I'm sort of trying to hold back and want it to be driven by stakeholders and also some public engagement. But some of the things that I imagine us doing is looking at what if you increased it, which I think will be fairly easy to predict just on the back of an envelope, but then also some tweaking around what if it was a slightly more sort of proportionate approach. So if we were giving higher payments to families where there's a disabled person living in the household, for example. So some of that as well. But yeah, at the moment I'm trying to reserve judgment.
Yeah, thanks, Alex, for super cool. But so just on that point, I wonder if there's any scope to like widen out and as well as tweaking this policy itself, you know, what might have been the gains, you know, if more money was invested in this, or instead, if you know this policy was not funded and instead I don't know, active travel or whatever was funded instead. Because that's what you see in the newspapers, right? Isn't it? We're wasting money on this and maybe
Yeah.
good to have evidence to kind of refute that.
Yeah, I agree. I don't know if we'll be able to do that directly in the simulation modelling, but I think we could say this is how much it costs, this is the health benefits, and then let's look to the kind of sort of synthesized evidence for other things. So yeah, I think our stakeholders are going to be really keen for that, especially the Scottish ones.
Where does this project stem from? Because I think it's really interesting that the kind of evaluation is not baked in at the very beginning into policy. So what's the driver for this and where's that come from?
I guess for me personally, I've been researching kids' health for a very long time, and inequalities and poverty has always been the thing. So then when we knew that the Scottish Child Payment was due to be coming in, then it was something we wanted to evaluate. And it's also sort of building on other work that colleagues have done, evaluating similar welfare policies in the union. So like Healthy Start vouchers and baby box. So it's sort of the time was ripe for it, and then there was there's the right expertise here, and I think we just managed to, as Laurence was saying, NIHR and particularly the PHR board who are funding this are very much interested in more upstream interventions of this sort. So yeah, they were sold to it as well. Sorry, does that answer your question?
Come from academia, I guess, rather than
yeah, it has, in that the initial idea came from academia, but with our valuability assessments we did lots of consultation, and then when writing the grant application, because it's quite broad, it doesn't just focus on the Scottish Child Payment, there's also plans to evaluate other local policies, so we were getting a bit of feedback into that as well, and they'll be sort of staying with us for the life of this project. But yeah, the idea came from here.
Great, thanks very much.
Thank you.
And next up we have Jala, who I think is joining online.
Yes, hi.
Hi, are you able to share your screen, or do I need to do something?
No, I think it's fine. Let me double check that you can see that. Okay.
Yeah, perfect.
Perfect. And you can hear me just fine?
Yeah.
Okay, great. Thanks, Claire. And thanks, everyone. I'm sorry I'm not in the room, but not feeling too well, so I thought I'd spare you. For this presentation, I'll be focusing on affective forecasting and psychopathology. I'll start with a bit of context around what I mean by affective forecasting, so a bit about the process itself, and then I'll focus the presentation on a recent scoping review that I've conducted looking at affective forecasting within the context of psychopathology. And hopefully, if I have time, I'll end with some implications and applications of this work. So I think we can agree that the future preoccupies many of us. Will I do well in my interview? Will I pass my exam? Will treatment work? Will I make rent this month? We hope to optimize future experiences, and our idea of a happy and healthy future drives most of our decision-making and daily behavior. Fortunately, people quickly realize, I hope, that the crystal ball is of no help in telling our future, and instead, we need to use our imagination, and that's exactly what we do. We make predictions about our emotional reactions to future events, and we base many of our decisions on those affective forecasts or emotional predictions. These predictions could have implications that range in importance from the flavor of ice cream I choose at an ice cream shop, or whether I go for a run later today, or whether or not to undergo treatment or surgery based on quality of life predictions. So its applications can be vast. So this process, affective forecasting, is our ability to estimate emotional consequences or emotional reactions to future life events. And again, the term we use is affective forecasting. And like other aspects of future-oriented cognition or other aspects of future thinking, affective forecasting is an important process that informs our planning and decision-making and underpins our intention and motivation in a lot of situations. And what we see and noticed is that we're seeing impairments and biases, we call them biases sometimes, in affective forecasting with various psychopathologies or mental health difficulties, which I'll speak to a bit more in the next slide. This is, in here, I'm hoping to show the process and how we might measure affective forecasting. So the way it would be is that I would ask you to imagine event X in the future. So let's say event X for us is the first day of term or hearing back about a job interview. Then I'd ask you to predict how you would feel when the event takes place in the future. So this is the affective forecast or the forecasted affect. Then the event takes place. So the first day of term happens, or we hear back about the job interview, and then we report how we feel about it then and there. And this is our experienced affect. What we typically see is that our predicted affect over here, so the forecasted affect, is more intense than the experienced affect. So we overestimate both positive and negative emotions in relation to life events. Okay, so and that's normative, that's expected, that's a normative bias that we see generally, and it motivates us to do things and it protects us from risk. However, and that's what we would call intensity bias. So the overestimation, the difference between our forecasted and our experienced affect. However, there are some people who are particularly prone to reporting extremely biased forecasted affect or intensity scores, intensity bias scores. So they're more prone to report ones that are extremely extreme in the sense that they're more than what you would expect on average. So as I said, there is a normative level of intensity bias. We don't actually know what it is, but it's there. We don't know which one is normative, which one is maladaptive, but people with mental health disorders tend to make extremely biased affective forecasts. And so we want to understand how this biased forecast or forecasting bias can be implicated in some of the functional impairments and decision-making impairments that might be implicated in various psychopathologies. Hopefully this clarifies the affective forecasting process. And this is where it sits within just general taxonomies of future thinking or prospective cognition. So this is to show where emotional predictions sit in respect to the process as a whole. Generally, we can see that it underlies intention and planning, and it comes after simulation. So after imagining our future, whether it's a particular event in our future, so that would be episodic, or if it's more general, so it would be at the end of the spectrum. So there's, it can be me predicting how I would feel in relation to a specific event or to just general state of the world. And this is where affective forecasting sit within this taxonomy. And again, this is just to show that it underlies then intention and planning, which are really important factors in the decision-making process and eventually in the behaviors that we make. Considering the heterogeneity in the methods used, as you can imagine, you can forecast your affect to various life events and measure it in different ways. So I wanted to understand what's been done to date within the context of psychopathology and summarize that literature to inform research directions in this area. So I've kept this as an exploratory study, and hence I've used the scoping review approach. And my overall aim was to summarize and synthesize the approaches used to measure affective forecasting and the intensity bias in affective forecasting, again, within the context of psychopathology. So not in broader literature, but specific to psychopathology. The research questions guiding the review included what methods are used to measure affective forecasting and what types of psychopathology have been assessed in relation to affective forecasting, and what are the main findings reported in respect to this association. And again, I kept it exploratory. I'm not making any conclusive statements. It's much more tentative because it's a scoping review. So as I embarked on the scoping review, I searched 3 databases of relevance, screened and selected the studies that met eligibility criteria, and then I charted the data and used descriptive synthesis to summarize the findings. 24 studies fit the eligibility criteria and were included in the scoping review. 16 of those studies were based in the USA, so that's over 65% of the studies. 4 in China, 2 in Germany, 1 study in Australia, and another in Canada. Of note, all studies included were conducted from 2012 onwards, and 75% of those were between 2018 and 2023. And this is just to show you that this is still kind of a young field of study, a developing and evolving area of study, which is quite interesting in and of itself. And there's lots of scope for development. Then in terms of affective forecasting paradigms, there were 10 studies with forecasted affect only and 15 with forecasted and experienced affect, and I'll show a schematic of what I mean by those in the next slide. And in terms of the psychopathology domains of interest, those varied across studies, but some included anxiety, social anxiety, trait anxiety, OCD, depression, anhedonia, social anhedonia, and schizophrenia, and others like trauma symptoms. So you can see there's a variation across the studies. This is a schematic just to summarize the affective forecasting paradigms used. And so 15 studies had the forecast and experience condition, and 10 studies only looked at forecasted affect. In the forecast and experience condition, 5 studies focused on general affect, so not a specific life events, but predictions around just mood generally and general affect. And specific life events, 10 of the studies looked at specific life events. Some of them used real life events that everyone would experience, such as Valentine's Day or St. Patrick's Day, so you know that it's going to happen. And then others used lab-based tasks, so particular tasks within the lab with pre and post kind of designs. And then the forecast only 10 studies used forecast only, and the majority used specific life events and using mostly hypothetical vignettes. So using scenarios and asking participants to predict how they would feel if they encountered those in the future. When it came to looking at the associations reported with psychopathology, there were important factors that I needed to consider based on the evidence base that was available. One really important one was the affective forecasting score, where we're looking at forecasted affect or an intensity bias. And if it was an intensity bias, was it a different score, or was it an interest in the forecasted affect while controlling for experienced affect? And those statistical decisions really make an impact on the results. And if you're interested in that, you can find that in the discussion section, or I'm happy to discuss it later. In terms of valence, were the events positive or negative? And was it positive or negative affect that one was reporting on? And then the operationalization, so was it a specific event or general affect and mood? And within specific events, was the life event, it had different features. Was it interpersonal, social, was it monetary or evaluative? And how do those operationalizations then impact on the associations? All these things are important to kind of take into consideration moving forward in this area of study. And finally, of course, the psychopathology domain of interest that was reported on, and mostly it was within the realm of anxiety, depression, and psychosis. As I said, I have tentative conclusions, so none of these I can't make conclusions per se, but those are tentative observations, let's say, from the scoping review. And what I found is that the negativity of affective forecasts and intensity bias seems non-discriminatory when it comes to the association with psychopathology, meaning we are likely to see increased negativity in emotional predictions and overestimations in the context of various mental health disorders. And this is consistent with our understanding of hopelessness and depression and threat expectations and worries and anxiety. However, blunted positivity in affective forecasts and blunted positive intensity bias seemed specific to dysphoria and anhedonia, which are features commonly seen with depression. And that's particularly consistent with the view that individuals with depression and dysphoria show difficulties imagining future positive events, which may interfere then with their estimations of positive emotional consequences of those events. And so that I'll wrap this up and just kind of briefly mention implications and future directions for this work. I want to be able to identify adaptive from maladaptive levels of affective forecasting and use that to inform clinical diagnostics and intervention, and develop targeted interventions that would enable us to manipulate the mechanisms underlying affective forecasts to improve outcomes. Here today, I focused on psychopathology, but as I said, the application of this work is vast and can include food choices, climate-friendly behaviors, treatment decision-making, and this has certainly been looked at within the context of cancer treatment decision-making and the implication of affective forecasting in that. So this is a growing area of research, and I'll just try and wrap it up here. Thank you.
Thank you very much. Does anyone have any questions?
Yeah, really interesting, Jala. I'm curious a little bit about I know you don't talk about it so much directly, but I wonder if you've got any thoughts on the simulation stage that precedes the forecasting. And I guess one of the things I'm wondering about is whether in some of these psychopathologies, just a simple act of mentalizing a non-occurring event, whether that simulation has also got some negativity associated with it. So even imagining in the future, I'll be in this room, what is that like? Even if that's nominally neutral, there's anything around that. So there may be some kind of baseline, kind of negativity that might infuse any subsequent effective forecasting.
Yeah, absolutely. And I think the simulation is actually one of the areas where we could potentially manipulate that based on detail and specificity, so that then we can, hopefully by doing that, we can affect the level of or the intensity of emotional predictions. So for instance, we know that in depression, the level of detail in their simulation of positive life events is it's general. There's no detail or specificity, right? So they struggle with that, with imagining those positive details within the event, which then leads to blunted positive affective forecasts. Whereas with the negative events, there's much more detail around the negative outcomes that might be occurring. So the simulation is much more negative in nature. So certainly the simulation bit is quite interesting in the process of leading to the emotional predictions, whether it be negative or positive.
Great, thank you. Really interesting.
If no one else has any questions, I have one. You mentioned briefly at the end the relationship with kind of climate-friendly behaviours and environmental behaviours. I suppose I wondered if you could say more about that and potentially interventions.
Yeah, sure. That's more of where I see this potentially applying as well. So it's not necessarily that it's been looked at in relation to climate-friendly behavior specifically, but we know that this process is implicated in choice and decision-making and behavior, and it could be applied in such fields where we need kind of urgent studies to understand what might get us motivated to engage in certain behaviors that we know will have beneficial long-term outcomes. And so it only makes sense for us to start to think to incorporate models and processes of future thinking in these types of studies to understand the underpinning motivations and factors that can help us make those healthy decisions. But as I said, we can learn from other fields of study that have already started to look at that, such as, for instance, studies looking at treatment decision-making in cancer that have started to look at affective forecasting and its implication there.
Great, thank you. Any other question?
Yeah, I was just going to ask, the effective forecasting is a kind of modeling your model and your prediction of your effective response to an event. How much does your modeling, or how much do you think about your model of understanding of how things work? So sorry, maybe I'm not wording this correctly, but your cognitive ability, so that your understanding of processes, how much those get impaired, and that then affects your effective response to an event. You know, so if you're thinking about a treatment decision, but you're modeling your understanding of the treatment is accurate or less accurate, and how you know a mental health problem might affect your ability to understand those things.
Yeah, I think if I understand the question, I'll try and answer this, or just kind of make sense of what I understand the process of affective forecasting to be. So developmentally speaking, the building blocks necessary for one to make emotional predictions, we see those established by the age of 5 and 6 in terms of understanding our emotions and being able to imagine future events and what we might react to and how we might react to those. Now, in terms of mental health difficulties, we know that mental health difficulties sometimes are implicated. You know, we see impairments in how we think and how we imagine events, and that might then bias our forecasts. And that's why it's so important to kind of be looking at this within the context of mental health, because it could be another form of impaired or dysfunctional thinking that then leads us to make decisions that won't optimize our happiness or our health and well-being in the future, because we're making decisions today based on predictions that are suboptimal. I don't know if that answers.
Yeah, no, I thank you.
Thanks. If there's no other questions, I think we'll just wrap up there. But thanks very much to all our speakers again, and also if we might have a couple of minutes for questions for Laurence, if anyone has any burning questions. And yeah, if you want to volunteer, you're more than welcome to just get in touch. And we're also looking for volunteers to join the organising committee of the seminars. So yeah, please get in contact if you want to volunteer.
Thanks, Laurence. So question I was just wondering if there's consideration of governance structures to support research across different cultures, and how imperative that is in following through with studies, because it is just such a huge hurdle. So, and I suppose England having different provisions for those research governances versus Scotland, and if that's been tackled.
Well, yeah, I mean, if I can understand your question, I mean, certainly in specific issues of research governance, like ethics and access to sites and that kind of thing. So that's obviously well established in the NHS. So there's just no basis on which that's supported in the council. And it's one thing where I was at a meeting last week where I actually sort of said, the council's kind of governance, clearly has people responsible for key aspects of governance within the council. It needs to be on their agenda. So they need to be developing ways in which ethics is appropriately done, so that people are protected and informed and what have you, as well as making sure there's appropriate governance around things like data and access to sites and that kind of thing. I mean, another part of the question might be, how do you get more of these things being evaluated? A little bit in relation to the question that someone had for Anna. I mean, and it's really interesting spending more time in the council. I mean, you realise that most programs that occur, they occur as a result of a political decision rather than necessarily an evidence-based decision. I mean, there's lots of different sources of evidence, and scientific evidence is quite a small part of that. And then once they've started, I mean, you've got people whose jobs and power within the organisation is dependent just on continuing to run that service. And so there's a huge resistance and never any process the demands, they actually assess whether what they're doing is producing more benefits than the harms or costs that are being incurred to deliver it. So that's the whole research culture piece is so important to this, to actually get the senior people in the council and senior decision makers to recognise that thinking about the kind of things that would be obvious to us should be part of what they're doing. And initially, when we had a lot of discussions last year, we thought we're trying to do this at a time when there's no money in the council is going to be a real problem for us. But actually, that is really helping us because the council and the Scottish Government and other governments, they're having to deliver more for less. So public service reform, and that's forcing them to do this. So it's actually creating a really excellent opportunity for us because the old type of governance, which was just we keep on doing what we've always done, can't work anymore because they're having to cut. I mean, we're working with the NHS through the HDRC. We're now actually doing a project for the NIHR where they're having to cut their budget by 30%, having already gone through a process of cutting all the services that are non-statutory. They're now having to make a further, and they're now coming to us to actually, what are the processes to get a bit of different types of evidence, including community perspectives, as well as, efficiency and outcome type evidence to help them with those decisions. So I realise we're over time now, but I'm very happy to take any other questions.
Thanks again.